So this session is on tubes. There are many who sit on the fence and wonder whether they should be tubing or not tubing. And so at the end of this instruction course, I hope they will have a fair idea, a deep idea about tubes and whether they should be doing it or not. So I have an array of speakers, star speakers here. The first talk is by Professor Kirti Singh. Unfortunately, she's still on the way. So we'll start with Murli? Yeah, can we start with you? Because Dr. Kirti is still not here. His topic is safe valved tube surgery.
Showing up on the. Thank you, Dr. Vanitha, for the invitation to participate in this. I think it's a lot of learning and a lot of work has gone into compiling this instruction course, and I'm sure we will all benefit from each other's presentations. Yeah, very good morning. And how do we do glaucoma valve surgery? And 7 steps to safe valve surgery. Obviously, we're not going to be, I'll not be able to cover almost everything of what we would like to cover, but in the time allotted, I think I'll try to say and cover whatever is possible. It's not moving. Yeah. The first and foremost step in the process towards AGV surgery is a good pre-op assessment. A good pre-op assessment, by that I mean the eye condition, the diagnosis, the secondary glaucoma, the type of problem which we're dealing with. It's gone to the last slide. Yeah, the eye condition and where do we want to place the tube and which quadrant we want to place the tube. That is the first step to assess where we want to do it. And second, of course, is to decide. Once you decide, most commonly we would like to place it in the upper temporal quadrant. We have the choice of placing it in the upper nasal quadrant and also the lower nasal quadrant. Usually the outer temporal quadrant is generally not a preferred site for placing the tube. And where do we place the tube? We can either place it in the antechamber, we can place it in the sulcus behind the iris, we can also place it in the pars plana in a vitrectomized eye. And preferred anesthesia would be local. And my preferred anesthesia technique is peribulbar with a combination of lignocaine with bupivacaine. And some surgeons also prefer a subtenant type of anesthesia. Topical anesthesia is generally a tough call, and it's not easy to do a topical anesthesia procedure with this AGV. We need to get a good exposure for us to place the tube, secure it, and place the tube into the antechamber, place the valve and the into the antechamber tube. We need to have a good exposure. I generally prefer an Ong type of speculum. If there is enough exposure, I would stop with that. Otherwise, we would probably put in a traction suture on a spatulated needle through the clear cornea, 75% depth, but little anterior to the limbus so that you don't come into the limbus and damage the limbal area. And this would enable adequate exposure of the operation site. And then the eye is rotated inferiorly. The traction suture is secured to the drape with a hemostat. The peritomy in the conjunctiva generally exceeds about 3 to 4 clock hours with a close Westcott scissors inserted in the subtenant pocket posteriorly, and you dissect all the adhesions. And you use a sponge or a cotton tip applicator, which is moistened, inserted as far posteriorly as possible, providing further dissection and hemostasis. I generally try to cauterize the very light cautery to bleeding points using preservative-free lidocaine instead of saline. This will actually reduce the pain during the cautery sometimes. The AGV is brought into the operative site and then primed with saline using a 27 gauge needle. The priming is a very important step to check whether the AGV is going to function or not. And then we gently tuck in the AGV into the pocket with the non-tooth forceps holding only the eyelet and the edge of the AGV. You do not touch the surface or the valve itself. Step 4, to secure the end plate, the valve itself, to the sclera, but at least 8 millimeters away from the limbus with 90 nylon. I use 90. Any blood vessels in the path of the needle which you're going to take a suture should be lightly cauterized prior to the needle insertion. The direction of the needle should be such that it exits through the eyelets in the end plate. The tube is repositioned into its natural position, and then you release the traction suture. Then the silicon tube is cut about 2 millimeters from the limbus, taking care not to cross the pupillary margin. You don't want it to cross the pupillary margin, so keep it about 2, at the most 2.5 millimeters. Use a 23 gauge needle to enter the anterior chamber between 1 to 4 millimeters posterior to the limbus, and we don't want it very close to the limbus, as far behind as possible. Up to 3 to 4 millimeters would be optimum. You can even mark it with, I'll show you the videos of how it is marking is done and where the tube is inserted. The needle is inserted parallel to and just anterior to the iris plane. The entry into the anterior chamber is done in a controlled fashion to avoid damage to the lens and to the iris. The tube is then firmly fixed to the sclera also. And these are several studies which have shown that the angle of the tube cornea angles, you see the way it is placed, at least 30 degrees should be there. So the aim is to keep the tube closer to the iris rather than closer to the cornea, and angle it and bevel it so that it does not touch anything. Even the patient is rubbing his or her eyes or squeezing or touching the tube should not touch the cornea if it is being placed in the anterior chamber. The tube cornea distance generally should not exceed 2 and should not cross the pupil. And the angle, as I already mentioned, so it should be at least 30 degrees or more. And making it shorter or more angled will actually start creating problems for us. So these are the video clips of how the procedure can be done. Conjunctival peritomy, 3 to 4 clock hours. And dissect the subtenon pocket. And you can also use a muzzle hook to sort of clear the adhesions if you have a lot of adhesions. And you mark the 8 millimeters from the limbus. And you can decide where you're going to place the sutures. You can also mark that as well. AGV is brought in and primed. The priming is possible at the 27G. And the priming is extremely important to check the patency of the tube as well as the valve. And then gently push in the AGV into the subtenon pocket, and just ensure that it is not too far back or not too far front. Again, check whether you have placed the edge of the anterior edge at least 8 mm, and a suture with 90, and the knot is rotated into the eyelet so that it is not poking out of the eyelet. Suture is very gentle. Make sure you don't go right through the sclera. And you measure again, and this is one method in which I have done using a scleral flap. You can actually measure about 4 millimeters, and then after the placement, mark a flap, and also make a scleral flap. This is the other suture. This is a scleral flap. Once the scleral flap is made, you pass in the 23 gauge needle into the chamber behind the iris. Cut it just enough to cross the pupil in this situation. You can either use a non-tooth forceps or a tube inserter and gently place it. It should be snug and tight. The needle track should not be lax. And then you suture the scleral flap and secure it. This is another surgery in which you have the, I'm not even touching the AGV. The edge is just held enough and you can use your fingers to push in the AGV. Tube is trimmed. This is being placed in the anterior chamber. Track into the anterior chamber with a 23 gauge needle. And instead of a scleral flap, another method is to use, this was a little older surgery with the patch graft. A scleral patch graft is going to be placed. And I am using sodium hyaluronate to form the chamber so that it is comfortable to insert the tube. This is a tube inserter. A tube inserter, very gentle handling of the conjunctiva. This is a small patch of the scleral patch graft. And a suture to mattress kind of a suture to keep the scleral flap in place.
I
And this is
request
a-
you to wrap up, Murli.
This is a phonics-based. This one last video, and then that's it, I think. And this is just a video to show you the post PK in which the tube, we had some difficulty in placing the tube. So just to show you that, just show you the last few steps. This is the place being sutured. And then had some difficulty in placing the tube behind the iris. So we had to use an iris retractor, iris hook, so we could see where the tube goes in, and then the tube is then placed. Move on. There's a no-touch zone for all these AGVs, so make sure you don't touch the valve part of the AGV. There's also a patch-free scleral tunnel, which I don't have the time to show you the methods. So patch-free scleral tunnel, which you don't really need to, as is a scleral flap or a patch graft. And make sure the conjunctiva is secured well and the AC is formed well as at the conclusion. And do it meticulously, and meticulous surgery goes a long way in ensuring, besides the post-op care of a topical steroid antibiotic, oral acetazolamide to prevent the hypertensive phase, and a little bit of mitomycin in and around the valve area is sometimes useful. I don't use it in all patients. Thank you all.
Thank you very much, Murli. Very meticulously done, and anything, anyone watching it would probably be able to replicate a safe surgery, valve surgery. I now invite Professor Kirti Singh. You're okay? Want some water? And we stick to the sequence now. She's going to talk about types of tubes and their indications.
So at the outset, thanks to Vanita for having me here. I don't do too many tubes because I'm in a government setup and the patients really cannot afford unless we get them. So I'll be talking about the tubes and indications. Hello. Audiovisual, it's not moving. No, neither down nor on the right. The tube is stuck. Enter. Okay. No. Yeah. Now it's okay. Thank you. So my time starts again back, huh? 8 a minute. So I'll be talking about some things new and some old. The journey started with Molteno and the Warwelt, and then it came to Emerth, which was FP7 and FP8, and the Krupin and Optimed are really now not there anymore. And then the non-valve came back, especially with the Autolab or the Adi valve, and now the Emerth cleared valve. But something is wrong here. I'm sorry. And can you just be here? What did you do right now to move it? Each time enter? Huh? I'll use a remote. I'll use a remote. Okay. So you remember the story of the tortoise and the hare? You'll be thinking, why am I talking about that in the tube IC? I'll come back to it. So we remember who won the race and why, and the things keep changing. So after the TVT study, which was the first landmark study, and which said about the cumulative probability of failure being a little bit higher in trabeculectomy vis-a-vis tube, the tube became the hare, and it came romping out to the goalpost, and increased in aqueous chance almost to 50%, up from 17% was the data in 2008, and it keeps going up. And now I've been told that many people have stopped doing TRABs in all over the world. Now, very recent studies, not too recent, 9 years old, the Emerth versus Barwell study, the AVB and the ABC study. My topic was which cases to use. So this inclusion criteria was failed trabeculectomy with antimetabolite, or disease with a high risk of trabeculectomy failure, or eyes with prior surgeries where conjunctival scarring is there. So basically tubes were used in which case the TRABs would not work or already had failed. And the 5-year data also talked about that the hypotony and the success was more in the Barwelt, but the hypertensive phase and the failure rate was more in the Emerth valve. Obviously, my topic is not this. I'm just skipping over this. So both the tubes, the valve and the non-valve, seem to be doing well. A study from the chief instructor, Adi, Dr. Vanita's study, she also talks about the recent ADI being pretty good and the success rate pretty high compared to AGV. But here also she talks about most of the patients had previous surgery done. And the last study I'll be quoting is the ADI study from the people of Aravind. And here also, if you see, most of the data is from the patients who were maybe anticipated failure of the tubes. So keeping all these studies in the background, the indications is failed trabeculectomy, multiple glaucoma surgeries, and in the primary surgeries only when the trab failure risk is high, like secondary glaucomas, or there's a high risk of failure of conventional surgery where you have the sick or the scarred conjunctiva. Now comes the new goalpost, the primary tube versus trab study, the PTVT study, and the 3 years follow-up after this. Now here there was no previous incisional surgery, surgery-naive eyes were taken, and their data was, again, let's go back to the hare and the tortoise, that maybe trab isn't too bad because the tubes did not do that well as trabs did. So, which you can do AGV, Barwelt, ACP now. Hypertensive phase we know is more in AGV. Barwelt has more hypotony. And ACP is an easier fixation to give very few pointers for the three. You already have seen the beautiful videos of Murli, so I will not be taking much time. But the ACP, the insertion technique is much easier. And for the AGV, something which I learned again from Vinita is to use not a scleral patch graft, but a corneal patch graft. And corneal patch graft, mind you, are much easier to get than a scleral patch graft. And I also use the scleral tunnel technique all the time, not at 4 or 5 millimeters, but at 3.5. And you can see that insertion was difficult, so I had to re-enter. And then you put the anchor the tube, and then you put the I can fast forward it. Yeah, this is the corneal patch graft. You can use that. But we did find a lot of tube erosions over the last 10 years I've been seeing, and patch graft I think is essential. Corneal decompensation is not a problem now because of our placement techniques, and the new ones are the iWatch implant, not yet available, but it would be beautiful if it would be targeted compression with an iWatch pen, and the Pearl glaucoma implant, which I believe is going to come. And here the tube erosion, which I was showing you, the risk is much less. And because the space is little bit less, so the damage to endothelium is less. And having said that, I obviously haven't used this, but it should be good. So back to tube, the tortoise and hare story. The tube story is still evolving. Trabs are not yet done with. They're still there, but the tubes are evolving and the new ones will come in. But my topic was indication and types, and I think I've covered that. Thank you.
Thank you. That was a very interesting take. I agree. It is a point to ponder whether you do primary tubes in primary glaucomas or primary tubes in secondary glaucomas. That's a point to ponder. Yeah. If we have time for discussion, we'll do that. I now invite Dr. Jayant Venkatramani Iyer. He's from across the Pork Strait from Sri Lanka, from a very good friend of mine. He used to be in SNEC. I think he still has, still part of the research team there.
I'll update everyone.
Right, okay. Now
it's under Dr. Jayant V. Iyer. You're looking at Amit Pandey. That's not me, sadly.
Yeah, AV team, please. Okay, over to you, Jayant.
Oh, that's why I should go over.
Yes, please. So he's going to talk about differences between valved and non-valved tubes.
All right, please reset the timer. Thank you very much for that kind introduction, Vanita. So I've now set up something called the Straits Eye Center in Singapore. We have a chain of clinics, and we hope to come to a place near you and work with colleagues like yourself, Vanita. And I'm very privileged to be invited by her, and to a very august audience as well. So I'm going to be reiterating the wonderful talk I'm going to be following the footsteps of Professor Kirti. Let me just move this along, which is not working. How do I press enter, is it? This ain't moving. I'm doing both. But, Maybe
ये
one
आ
of
रहा है
you-
क्या भैया? Hello?
It's not working, and
none of them
Audio
are
visual.
working.
when you start, please reset his timer. Thank you.
You press this, right?
Yeah, but he hasn't switched it on yet.
It's
Now it's coming. Oh, you can play with. Yeah.
oh, I see.
This
Okay,
one is a
okay.
video, so you
Okay, okay. Oh dear.
you slide smoothly.
Like that. Okay. Oh, okay. Let's. Okay, don't worry. I'll take over. It's fine. Let me just move to the next slide. Don't waste time. Alrighty. That's a guy pondering to be or not to be, to tube or not to tube, to further play on Manita's words. Actually, it's what Professor Kirti said is very interesting because honestly, I've been doing less and less tubes with time. Interestingly, despite the increasing complexity of cases, let me just use this instead. All right. No financial disclosures of relevance. I'm going to reiterate some of the points that Professor Kirti made with regards to glaucoma tube shunts. There's an overall history of glaucoma surgery, which really started off with this German physician von Graefe with regards to peripheral iridectomy for angle closure, but really focusing on the history of tube shunts per se. It started off with the humble horsehair sort of seton that was placed in anterior chamber that served like a wick to drain the fluid, but very soon people realized that didn't quite work. And it took about 60 more years for Molteno to finally realize that actually we might need to use more than just a wick to drain the fluid out to a subconjunctival, subtenon space in a capsule, and then slowly that percolates and drains out towards conjunctival veins, and that's how this device kind of found a resuscitation. And now we are doing more of the same. Krupin came up with a valved mechanism. Barwell, to South African, came up with his version of a valveless implant, and Ahmed, who is of Indian origin actually from IIT Delhi, moved on to California to create the Ahmed glaucoma valve device, which many of us do use. And of course, 2000s has been an explosion of many different minimally invasive glaucoma surgery. And honestly, beyond just that, glaucoma has moved towards earlier diagnosis, earlier pickup, earlier management, and better optimization. So honestly, with especially in Singapore, I'm seeing a lot earlier glaucoma, and just even removing the lens along with MIGS, with or without MIGS, is allowing me to, put away such invasive surgery. Oopsie daisy. What happens there? We go there. Alrighty. This works now. So I will not go through the indications because you have already beautifully covered the various indications. To summarize it, it's basically refractory glaucoma, secondary glaucoma after other incisional surgery where the conjunctiva is a bit screwed. Then you can consider doing tube surgery. But if the conjunctiva is too screwed, is too cicatricial, also tube surgery is a contraindication because you're not going to get a good tube there. You're going to have a lot of problems. You might want to consider other procedures. So the tube killers really are basically better invasive, better medications, better trabeculectomy techniques with mitomycin C, and hawk-like control post-operatively, and diode laser with the micropulse. I'm using that a bit more frequently to reduce medication burden. Valve, so I was supposed to talk about valved implants and non-valve, so some of it is a repetition. I will gloss over the repetitive parts. Basically, the Ahmed tube is an archetypical valved implant that we use. It's a silicone tube which is inert, connected to a silicone sheet valve. The valve system works in a Venturi manner where the inner outlet is diameter is smaller than the outlet. So there's a pressure differential governed by the Bernoulli equation, and it's designed to open at the opening pressure of 8 to 10 millimeter Hg. The truth is this, though. It's so design closer. The truth is, when they have done in vitro studies, they have found significant variability in this. So if it were to be this way, honestly, it'll be awesome. But the truth is, even in Ahmed glaucoma valved implants, we do see hypotony. Partly they say it's due to peritube leak. Partly it could be the valve mechanism. We have seen a couple of excellent videos on surgical technique for Ahmed, but basically suffice to say it's a bit more straightforward than valveless devices in terms of insertion, in terms of not really requiring you to find the muscles to place it snugly in the subtenon space in the supratemporal quadrant. Typically, you don't need ligating sutures, you don't need a ripcord suture generally, so it's relatively straightforward. The advantages are earlier intraocular pressure reduction. You don't really have as much diplopia or strabismus or hypotony events, especially in the early phase, as compared to Barwell's. When I was doing my fellowship in Johns Hopkins, we did an equal measure of both Barwell's and Ahmed. And honestly, the studies kind of prove themselves where in bowels you have a lot more surprises, especially when the tube opens up. And in Ahmed, you get a little less of those surprises early on. But overall, the bowel seems to have better IOP reduction. So typically, there's higher medication burden. There's typically quite often, they see in some studies 20%, in some studies up to 80% of a hypertensive phase, which is attributed to the pro-inflammatory cytokines that are present when the aqueous immediately passes through. So you remember, when you do a valved implant, immediately it starts working. So it immediately starts draining fluid, and you get a lowered pressure. But they say the pro-inflammatory cytokines induce very quick blood fibrosis, resulting in a hypertensive phase. So many of us very quickly start off the patient on hypertensive agents like Cosopt or Timolol to kind of reduce the aqueous, to kind of suppress the aqueous production. And that has allowed us to have better success rates, at least in Singapore. And actually some studies have shown that. The non-valve implants like the BGI come in 250 millimeter square or 350 millimeter square and plate result. Because what we do know is that the larger the plate, the better the pressure reduction in general. Some studies have shown that this may not be that clinically significant. So many of people are just sticking to 250 because it's easier. You don't need to sling it under the muscles. But most studies like AVB, ABC do compare the 350 versus the AGV. I will not talk about studies because we have a person who's going to give you a nice overview of all the summary of the studies. Surgical technique is slightly more complex, a bit more leche, as we call it in Singapore, a bit more cumbersome is the English word for it. But essentially, it involves similar. We try to place it in the supratemporal quadrant. There's always a need for ligating sutures because oddly, you would kind of want to ensure that you kind of keep it closed with a vicral suture typically in the first 6 weeks. And we are really waiting for a capsule to form around the plate that you can see that I'm inserting there. All right, and the large capsule will then form a nice contained area for the fluid to then flow, typically at the 6th week mark onwards. This, I'm surprised, happens quite like clockwork when I use Vicryl. I realize that 42 days, 43 days, 44 days is when I start seeing a sudden lowering of pressure. And some people, previously I used to place this ripcord as a safety mechanism, which has an inferior outlet. That time is not fair. I have a bit more time. The inferior sort of conjunctiva for you to allow to remove the ripcord should there be some resistance. But in summary, that's kind of the main difference between the Ahmed and the barbells. Moving along. So this, I think no one showed you the barbells yet, so I'm just going to show you that. There are many techniques to insertion. One technique is to tunnel it. Another technique is to just put it about, like he says, 2 to 3 millimeters behind the limbus, enter it, and then in the US, I had access to split thickness, half moon corneal graft, which was beautiful, and it kind of covered it well. In Singapore, because we do so many traps, I'm just used to doing a long flap to cover the tube. And actually nowadays I do the technique which is very similar to the one that Aravind doctors are talking about, which is the tunneling technique, to not even have any flap or any of those things. And that seems to work pretty well, at least in the last 3 to 5 years. As we have already discussed, it has better long-term IOP reduction, reduced medication burden, but it comes at the cost of earlier part of the treatment. The IOP is not well reduced because you are ligating the suture, so it doesn't work in the initial phase. So you might need to use a lot of glaucoma drops, and there might be a sudden drop in pressure at the 5th, 6th week mark, which you have to be careful of. So you have to watch them very closely post-operatively. There's another Paul glaucoma implant which was actually developed by my colleagues in Singapore in the National University Hospital System. They tried to kind of combine the advantages of both. They wanted to have a larger plate so that there's more drainage, but they also wanted to have a smaller tube without a valve such that there's reduced chance of hypotony. Is there truly reduced chance of hypotony? Studies have shown that they still get hypotony, unfortunately. They do have those complications, but what they have found in their not so long-term data over the last 2 to 3 years is they tend to get a bit better results than Ahmed. So in NUH, they exclusively use a Paul's glaucoma implant. In the Paul's glaucoma implant, they do not, because of the lumen size of the barbells and AGV is about 0.3 mm internal diameter. The lumen size for the, the Paul is about 0.12 millimeters. I'll be done soon, don't worry. So just very quickly, typical case studies to illustrate the point of when we use what. An example would be a neovascular, single-eye neovascular patient, glaucoma patient with significant peripheral anterior synechiae, which would really not do well in a trab. In this case, he was refractory after having undergone the bilateral TPPV vitrectomy and endolaser. His eyes were cooked. Pressure was 30-40. He needed quick drop in eye pressure and better management. So we anti-VEGF'd him, and we also put a tube in his eye. Within 8 months, it did not succeed because this patient is also non-compliant to medications. And I actually managed to do a limited transscleral cyclophotocoagulation. And over the last 2 to 3 years, he has stabilized very well. But this is a tough patient because there are a lot of other factors. A typical case that might require a BGI as opposed to a valved implant would be, for example, a 70-plus-year-old primary open-angle glaucoma patient. I'll be done. For whom there's a failed bleb. And he did very well. Like the sixth week, AC went flat, hypotony. We had to stent the tube. So we had this technique we have described in the literature where we use a supramid or sometimes a nylon Prolene suture where we go in across intracamerally to plug the lumen, and that worked beautifully for this patient. In summary, valved and non-valved GDDs have a reasonable success rate. You have to watch out for each one's complications and each one's different techniques. And ultimately, it's surgeon preference, surgeon comfort, what's available to you, what works best for the patient, because we have a plethora of options to choose from. Thank you very much.
Thank you very much, Jayant. It does tend to get a bit rushed. I'm sorry about that. We got to accommodate all speakers. Next speaker is Dr. Amit Pandey. He was my partner in crime at Center for Sight. He's now moved on to Muscat, Oman. His first talk is on complications of valve tubes. Amit.
So I'll be talking about, oh, this is not moving. Okay, it's moving now. I'll be talking about complications of valved tubes. I'm going to skip all this because this has been covered. I'll be mainly talking about the AGV because that's the most common valve tube that we use. Indications have been covered. I'll directly jump to the complications. So you can have intraoperative or post-operative complications. Let us take one at a time. You can have a conjunctival buttonhole. So like in any filtration surgery, any glaucoma surgery, you have to handle the conjunctiva very gently without using those sharp tooth forceps, only blunt forceps, and maintain hydration to maintain the elasticity of the conjunctiva. And if you have a conjunctival buttonhole, you can do a conjunctival flap or a patch graft. You can also damage the valve by either over priming it. This is important. You should not over prime your valve because or you can damage the valve housing by touching or grasping the valve, the no touch zone that I'm shown here. If you do that, you will end up with a non-valved implant instead of a valved implant, and even without an occlusion of the tube. So day one you'll end up with an hypotony, shallow AC and overfiltration. We can have a false passage because it's kind of a blind technique that we do when creating the needle tract for the tube. So what I would suggest is if you are putting it in the antechamber, be parallel to the iris, like Sir told, more towards the iris than towards the cornea. And also one trick is to always trim the tube after you have made the tract, because if you have a false passage, you have to make another passage and divert the tube there. So if your tube is short, you won't be able to do it. Over shortening of the tube can also happen. So what you need to do is you put the tube on the cornea and take 2 to 3 mm at least. I would suggest if you are beginning with the surgery to make it a little longer. You can always trim it shorter, but making a shorter tube longer would be difficult. That can also be done. I'll show you a tube extension as well. Post-operatively, you can have poor cosmosis. That is usually because of the graft that we use. You have a white patch on the over the cornea. This is Totoplast, which is a scleral patch graft. With any scleral graft, you might see that poor cosmosis. You can use corneal graft, like Sir told. I've shown this is a corneal stromal lenticule derived from SMILE surgery. I've used 2 or 3 to cover the tube. This is absolutely transparent, so gives very good cosmosis. You can also use this U cord, which is an umbilical cord derived graft, which is also semi-transparent and not very costly. So this also gives good cosmosis. Or you can do like shown in the previous videos. You can make a scleral tunnel and or a long tract. so that gives the best cosmesis, I feel. If you have a tube retraction, what do? You can use this method. This is a 22 gauge angio catheter that I've used to extend the tube. This was tube retraction 2 weeks post-op. You cut the silicone tube, you use this angio catheter, dilate one end, put it in the stump of the silicone tube, and pass a ethylene suture through and through both the tubes to secure it in position. Trim the angio catheter and again dilate the other end and put the cut end of the silicone tube that you had cut initially. Make sure that only the silicone tube is entering the eye, because the angio catheter is probably not that biocompatible like a silicone tube. You can also use the cut end of a old AGV tube, that is called tube in tube technique. What if you have a long tube the other way around? This was a patient who had a flat anterior chamber. Probably the valve failed. This was 2 months after the surgery. He went to the gym and lifted some heavy weights and landed up with this kind of a flat AC, cataract, and a long tube in the AC. I'm sorry. So we ended up doing a cataract surgery. This is absolutely flat, so I had to just form the AC with some BSS first, and then once I got a little space, I made the side put a little bigger, and then with viscoelastic I could form the AC completely. Made the main port for the cataract surgery, and through the main port, using a Vana scissor and a micro-access forceps, I could cut the tube a little shorter. I could trim the tube inside the anterior chamber itself. Completed the cataract. I'm not going to show that. And then I used this 40 ethylene to stent the tube itself. So 40 basically leaves a few microns around the suture for some amount of aqueous to drain. So if you have a valve failure or you have an overfiltering valve, you can use this. This goes in very easily. I'm using 2 micro-access forceps to stent the tube. This patient did really well. He had 16 pressures with, I think, no medications post-operatively for a good amount of time. So you can also have a block tube by any of these: blood, silicone oil, vitreous, and iris. Also, hypertensive phase is something that we commonly see with valved tubes. This usually happens after a few weeks after the surgery, and basically the bleb around the plate is maturing, and because of that it takes a little time. So if you don't pay attention to that, you will have high pressures. We can manage it medically, and most of the patients, they do well with medications, usually topical medications if required. And digital massage plays a very important role in this this condition. And but even if with full medications they don't do well, or the tube fails, then you can do a needling with antimetabolites, which usually doesn't work with tubes, at least in my hands. Or you can do a revision, or you can place a second tube in the eye. These are a few patients that I had put a second tube. Tube exposure can happen, so you need to repair that. This is an inferior tube with a PK which exposed 3 times. I've used scleral patch graft, I've used a corneal patch graft, so in this case I used the corneal stromal lenticules derived from smile surgery. I used 4, and over that I've put a conjunctival autograft also. So for 5 layers. Initially she did well. She also had 2 tubes, so initially also she did well, but again this has exposed, and I've sent that patient to Vanitha ma'am. And you can also have corneal decompensation. So this patient had a PCIOL in the AC and also a tube. I'll just take a little more time. I'll compensate for in my next talk. So we did a open sky tube shortening and removal of this this PCIOL in the AC. This decompensation was mostly because of the IOL rather than the tube, because the tube was well placed, not very long. But still I shortened it because I had the chance, so that it goes away from the graft area. It should be only in the host section. So that was an open sky shortening. Also you can have an infection endophthalmitis. Diplopia and squints are very rare with AGVs. The last thing that you might have to do is, in a painful blind eye, you might have to remove the implant. I'm removing an ADI here, but the concept would remain the same. Yeah, so a lot of hemostasis, a lot of blunt and sharp dissection, because the tenons becomes very thick over the plate. You need to isolate the tube first and remove the tube from the AC first. And then you can basically release one edge of the tube, one edge of the plate from the side, and through that opening itself the entire plate might come out. Also there are holes on the implants which the fibrovascular tissue grows into, and you need to cut that to release the implant from the eye. This patient was a painful blind eye, but he did well after the surgery. Yeah, that's it from my side. Thank you so much.
Thank you so much, Amit. There are, of course, complications that overlap in both types of tubes. I'm going to talk about safe non-valve surgery. This is something very close to my heart. I do wherever possible non-valve surgery, and I don't have any relevant disclosures for this talk. It's not moving again.
I'll take the time to introduce you. She's a very, very competent surgeon. As you can see, people refer her their problems to her, and she keeps redefining her boundaries. That's what I like about Vinita. You keep evolving. So over to Vinita Bhatak.
Right. So we don't have too many drainage devices available in India, but we do have some that are indigenously made. The ADI, of course, both 350 and 250. It's designed, the prototypes were all from Barweld. And of course, now we have the Ahmed ClearPath available, both 350 and 250. So the non-valves are, both 350 and 250, but it is really the 250s that are taking over. The recently available ADI 250 being very, very advantageous in terms of it being cost effective. And you heard about Paul glaucoma implants, still not available. We are hoping it will be launched in this meeting for India. So the main issues with non-valve tubes, of course, is hypotony. That's it. So every effort has to be made to control this hypotony. And of course, you need protection of endothelium. This is, these, in my opinion, are the two biggest things related to tubes, hypotony for non-valve tubes. And so protection of the endothelium is a concern for all types of tubes. So the expected post-operative course of a non-valve tube is hypotony. So you have to make preemptive efforts to control this initial hypotony. How can you do that? You do with temporary occlusive ligatures. You use ripcord. I use ripcord all the time now. When the tube is occluded, it results in early post-operative hypertensive phase. This is temporary. Okay, this also can be managed. So I'll just list out a few procedures and then we'll see them how they can be done. So to prevent the early post-operative hypotony, you use a ripcord. You either use Supralon. This is our indigenously made from Arvind 30 nylon, or Supramid, which is not available in India, or you can even use the 40 Proline. And you use temporary vicryl sutures as occlusive ligatures. You can also use a little bit of heavy molecular weight OVD, and you can do a two-stage procedure. You can first implant the plate, And then 4 to 5 weeks later, when a thin capsule has formed around the plate, you can then introduce the tube into the AC or sulcus. Sulcus is my preferred destination. Intraoperative modifications that you can do to overcome the initial hypertensive phase now, because you've occluded the tube, is venting slits or fenestrations. You can use a vicryl stent as well, or you can restart medications, or you can even do an orphan trabeculectomy, meaning without antimetabolites, something which is only expected to last 4 to 5 weeks, and you're not going to work heavily with it to make it succeed. So where non-valve tubes are concerned, my biggest tip is to prepare the plate before you actually put it in the quadrant, and that it helps making the surgery very, very controlled. And when you do the occlusive ligatures, turn the plate over so that you don't have a knot on the anterior surface, so that if you need to laser it, you can still laser it. And I have done that several times. So just let's have a look at Ahmed ClearPath 250 first. Basically, it comes with a pre-placed stent. I leave it in position all the time. I do the occlusive sutures. You can see it's the undersurface where the knot is. And then I'm doing fenestrating slits anterior to it, and I'm also leaving a 6-0 vicryl stent. The same thing can be done on a ligator block. It's much more controlled if you're just starting. This is a steel block, basically, where you can use 30-gauge needle to create the fenestrating fenestrations, and then you can occlude as well, as you are seeing there. And always check, keep checking that you have occlusion and you are getting initial filtration only anterior to it. Now this is in slow motion. What I wanted to show you is how you can fold this plate like a taco and hold along the long axis of that plate, and then insert into the pocket very small conjunctival incision, not more than 5 millimeters, and then just grab hold of the distal end of the plate closer to the eyeball and just unfold it. Very advantageous. Remember, these Ahmed ClearPaths have these dog ears, so you don't have to go as far back as well to suture it. You don't need to go 10 millimeters. You can do it at 6 millimeters. And contrary to what you've heard so far, I leave my tubes pretty long, and I'll tell you why. Okay, this is in the sulcus, and most of my tubes are in the sulcus. I don't, especially in aphakic, pseudophakics, I would not put it in the AC. And then the rest of the surgery is then very much similar, except when you have the ripcord, you insert it into the inferotemporal pocket, and the free end, I put it under the patch graft. I used to use a lot of corneal patch grafts. Unfortunately, I don't have too much access to it now. I tend to use the rims, the corneoscleral rims that are discarded after PK surgery also. And then you close it with... This is going to be a game changer in India. You can see such a small incision through which I inserted the AIOS2025-IC321-To. This too, I'm placing a ripcord because it doesn't come with a ripcord. This is Supralon, 30 Supralon, and the rest of the procedure as you just saw. But again, what is important is that you can also fold it just like that and place it in the pocket. And that once it's in the pocket, you just unfold it and then suture it. I use 6-0 stay suture. I pass it through the holes, and then I do safety sutures on top of it with 9-0 nylon. And AIOS2025, of course, requires dissection of the muscles, as you all know. And the rest of the preparation is the same. Vicryl stents, fenestrating slits, whatever you want to do. Here I'm placing a proline because it doesn't come with the ripcord. and preparation of the plate prior to putting it into the pocket is useful. And the 350 also here being prepared on a ligator block, and this also requires placement under muscles, as you can see there. Just forward it for you. And because it has dog ears, you don't have to go so far back. Okay, endothelium protection is very important, so that includes placement of the tube and the length of the tube. Pseudophakic, aphakic, preferred destination, sulcus. Phakic individuals, if there is cataract, do surgery together with it. If the lens is clear, that becomes contentious. And pars plana, I reserve when patients have trauma and things like that. You can see here in this particular case, just fast forward it for you. I'm placing it in the PI of the trab. I hope you can see that. Visibility of the tube there. And you know, in PKs, in all these conditions, I would always do tubes in the sulcus. This one, patient is awaiting a DSEC, and I placed a tube in the sulcus. And ICE syndrome, all the time, I place it in the sulcus. There is retraction. Please remember, there is retraction. So longer is better. And longer is better. Here you can see in an ICE syndrome patient, the tube has retracted. Why longer is better? I skip this now. Longer is better is because endothelial cell loss will occur where the tube enters the AC or the sulcus. But a longer tube, even in AC, prevents that excursion from the tube to the endothelium is rather long. So when the eye is being squeezed, it actually does not touch the endothelium at all. And this has been proven. There are several studies. This has caught my attention many times. And also, of course, in shallow ACs. Please remember. And he was saying Venflon cannot be put. I have put Venflon angiocatheter inside the eye as well. It's not easy, but you can do. The end result with non-valve surgery, you can look at the bleb. It's beautiful. Compare it to an AGV bleb here in its glorious hypertensive phase, unfortunately, really high. So knowledge of and execution of meticulous intra-op maneuvers result in safe non-valve surgery, and placement of the tube in the sulcus is protective for the endothelium. Thank you so much. I'm really sorry I overstepped. Next is complications of non-valve surgery. This is the nightmare of all surgeons, glaucoma surgeons. And this difficult topic is going to be taken up by Dr. Ganesh Raman from our end.
Thank you, Dr. Vanitha. Nice to be here. Thank you for the invitation. I thank AIOS for the opportunity. So I'll be speaking to you on complications of non-valve device. We saw how meticulous the surgery has to be, but unfortunately complications do occur. And as with complications and with this laptop, we are all having the same issue. So it has, I think AI has crept into it. So as mentioned previously, hypotony is a significant factor. If you see the Indian studies as well as early and late complications, you still have significant hypotony with the non-valve devices. And our formative years of learning RD, we published in 2019, and a series of complications, and shallow chamber with hypotony was quite significant compared to even other studies. So the first thing which is what Dr. Vanitha mentioned is prepare the tube outside. So this is something which you should know. So in the first few tubes, you may have a beginner's luck. Then after that, you get overconfident, and then you get something like this. So this is something which I'm sure everybody has experienced. So best thing is to have another tube. And the other trick is that nice published article is that you could remove the small bit which is attached to the plate. Remove that, you could pluck it out. But it's quite difficult. It's actually molded nicely. And then insert the remaining tube into the opening. And then if you want, you could tie it with a suture. And then you could continue to proceed with the surgery. But be careful, it may not have a very snug fit. So shallow chamber and hypotony, especially when multiple tracks are made. So if you have multiple attempts into, that's what happens initially. So you have to make sure that you suture each entry separately. If they are all bunched together, put a suture, infinity suture all over, make sure those don't leak. And very peritubular leaks, definitely if the aqueous can flow into the tube, it can also flow outside of it through the channels. And one thing which you have to understand is you can control the point of entry, but very difficult to control the point of exit. So where you're going to exit comes with many years of experience. And avoid using tooth forceps. This was alluded very nicely by Dr. Amit. And avoid using sharp tooth forceps, especially when you're suturing. So when conjunctiva is covered and patch graft is covered, inadvertent suture use of those forceps can cause trauma to the tube. And if you have slightly higher incidence of hypotony compared to a non-valve device, compared to a valve device, about 4.37% more than AGV. And malposition and plate exposure, you can see that the plate is not actually in a correct position. You can see a little bit of plate exposure here. So sometimes if you're not hooked the muscles properly, you may split the muscles, the plate may go in, and then after that, after you're sutured everything, after a few days you get an idea like this. And this is what causes motility disorders, diplopia, ptosis, if you have a plate exposure, which you can see nicely in this quadrant here. This area you have a plate exposure, and that's the ridge of the RD device. Tube exposure, if you look at this patient here, nasally you'll have a small area of tube exposure. Once you retract, you see how much the peritubular leak, actually aqueous has a lytic property. Wherever it enters, it will melt the tissues which are foreign to it, sutures, patch graft, everything. So this is what has happened, and if you notice, instead of taking the tube more nasally, the surgeon has done it more temporally. So exposure to that causes all these issues. And also compressive forces of the lid over this area will cause tube exposure. So this patient has a bleb here. So what we did is we redirected the tube, just like Dr. Vanitha mentioned, through the PI into the anterior chamber. So we were able to use the tunnel and track technique, which I do. It's a total 8 millimeter tunnel, and then you have a patch graft still remaining there. We have not touched it. We are allowing to heal over it, so you have a nice epithelialization over the patch graft. You don't have to really remove it. So raised intraocular pressure leads on to hypertensive phase. You get that even in a non-valve device. So we use a 7-0 proline. Everybody has shown a 6-0 polygalactin suture, which opens in 48 days. We use 7-0, which opens in 28 days. And if it gets prolonged, it can lead to hypertensive phase. Dr. George Putran has mentioned that you have a hypertensive phase of about, Dr. Senthil, Sirisha Senthil mentioned 24%, which resolves over time. And Dr. George Putran, in his series, he has shown that by about 6 months, 94% of the cases of the hypertensive phase with a non-valve device sort of resolve with medication. And they had end result was not different between people with hypertensive phase, without hypertensive phase. And 16% of refractory pediatric glaucoma will have a hypertensive phase. So another thing which you have to see is we are all taught to leave a little longer length of the tube on the sclera. So you make a C-shaped loop or S-shaped loop, and that if loop is very sharp bent, then that can cause a prolonged hypertensive phase. That you have to keep that in mind. You might have to go back in and sort of readjust the tube. So just keep that in mind again. And this is what Dr. Vanitha also showed. You have a nice diffuse bleb, but then this leads on to hypertensive phase. Endophthalmitis is a serious complication. In the TVT study, as mentioned, as 1% at 5 years. And exposed implants have a higher rate of infection, 16% compared to 1%. And exposed inferior GDDs definitely have severe high chance of infections, 47% versus 8% in the superior. Younger patients aged less than 18 years have higher incidence of endophthalmitis. Sorry, and so what do? You have to explant it and do also vitrectomy. Removing the nidus helps while you explant it and lowers the rate of evisceration, enucleation, which is actually 15%, but unfortunately does not lower the rate of phthisis. And general recommendation is to remove the implant and perform the vitrectomy, but unfortunately this does not lower the rate of phthisis bulbi. Tube to cornea touch. If you don't maintain the angle, which has been alluded previously by the previous speakers, you will have a tube to cornea tip touch, tube tip and cornea touch, and this can be seen very nicely in AIOS if you were to image them. So long tube is a boon. The reverberation which happens when your eyelids close and the intraocular pressure rises, that sort of blunts, it doesn't come very close to the cornea, and these are some of the examples of long tubes which we leave in the chamber as long as it doesn't come into the pupillary axis. Tube retraction has been alluded very nicely, and you have many mechanisms by which you can lengthen the tube. It's why it happens is because you leave a small tube tip in the anterior chamber and you see that gonioscopically, and the movement which you make is usually in formative years, it should not be left to right. If you make that left to right movement, you are increasing the tunnel. So the tendency is to make a left to right movement. That accommodates the tube if it were to retract. So that's why it causes retraction. So we immediately redo the surgery and insert the tube back into the anterior chamber. And ideally, the tube should be like your extreme right image. It should be right in the sulcus, very close to the ciliary body, and you should be able to see it gonioscopically. It should be pretty long, but in this case, if you see, the tube is just behind the iris, and the iris is, the limb of the PI is blocking the tube tip. So the incidence is about 2 to 3%, and Dr. Pathak has published that in her publication. And suprachoroidal hemorrhage of the, I think this is the largest series of suprachoroidal hemorrhage published from India, Dr. George Putrain's work. So they had 7 patients out of 986 eyes which had suprachoroidal hemorrhage, 4 in pediatric and 3 in adult eyes. And the risk factors include hypotony, myopia, microcornea, microphthalmos, post-vitrectomy staphyloma eyes, and end result, 3 patients had phthisis bulbi in those eyes which were pediatric cases. So coming to late complication, this is not uncommon. Dr. Vanitha has already mentioned the first slide, hypotony, you have to live with it, and you have to rectify it, make sure it doesn't happen. And you can have that because of the lack of flow restriction. Late is about 3.5%. Be careful of metabolic syndrome patients, patients who have uncontrolled diabetes, uncontrolled hypertension, they are obese, and they also have compromised carotid circulation. So because of that, ocular flow, the aqueous humor production will not be constant. It will always fluctuate. So they won't have a constant, sometimes it will reduce the aqueous production. And be careful of our patients who have undergone cyclodiode photocoagulation. After that, hypotony is very severe in non-valve device. So if you have that, use a smaller plate or use a Paul implant or use something like a ACP, which has a smaller surface area. And eyes which have anti-segment abnormalities, they have a tendency to have hypotony. When the ligature opens up, like I said, 42 days for 70 and 42 days for 60 and 28 days for 70, the potential difference between the antechamber and the conjunctiva was huge. So few days before that, 1 or 2 days before that, we pump them with Dimox. Once the potential difference reduces, then the tube opening is not very dramatic, and that definitely reduces the rate of hypotony, number 1, and reduces the prolongation of hypotony also. So a dramatic opening will cause severe hypotony and continue to prolong it. You can always reverse it by putting a intraluminal ripcord suture, as already been showed by the previous speaker. And if you have hypotony, you have secondary immediately corneal decompensation. So that's something which you have to be careful about. And this is what we are talking about. So you can see this aphakic patient who has got trauma, who has got a diode laser done already. We have kinked the tube with a 90 proline. So you put a 50 proline in the tube, put a 90 proline around it, kink it nicely, remove the 50 proline. So you're reducing the diameter, internal diameter by 3 from 30 to 50. You're reducing the 50% size of the tube lumen. So once you remove it, you can see that you have reduced the lumen size. So this is how you can prevent hypotony. You do it outside, it doesn't increase the dimensions of the tube. It goes in through the tunnel and track very smoothly. So this is again a patient who is aphakic and, pseudophakic, but pediatric childhood cataract surgery has been done. And you could do this bringing the tube outside through the sutures which you see here. We have made an incision in the cornea, brought it out, kinked the tube and put it back in. And he's got 2 ligatures, something like that. So you could use a 902 to ligate the lumen size also. And this is another, cataract. You have a significant increase in cataract, especially if you have anti-segment abnormalities, eye syndrome, who develop cataract after tube implantation. Inflammation, something which few publications have talked about. So incidence about 0.6 to 4.4%. Pediatric, you have higher incidence. Patients present with a lot of symptoms. And people who are vulnerable, mentally challenged patients, children, caregivers is different from an escorting person. So bioavailability of topical steroids is questionable. The main issue in these eyes is in bad pseudophakic eyes which you have a bad pseudophakia and you have access to the vitreous cavity, you have a high chances of inflammation, ongoing inflammation. These patients will present with multiple pigments on the intraocular lens. We have 3 or 4 patients like that. You have to constantly keep them on steroids. And this patient had something like that. So this is another patient who has, you can see bad pseudophakia. You can see the lens edge actually here, very close to the pupil margin, and you have access to the vitreous cavity, and she presents with inflammation recurrently. So these are eyes. The logic here, we are not able to understand why this happens, but I feel that you have a two-way flow in the non-viral devices. The flow from the conjunctiva can also enter into the cornea or into the antechamber, and that causes rebound inflammation constantly. So you have phases of hypotony and hypertensive phase. Sometimes the pressure is low, sometimes the pressure is high, and this causes constant inflammation. So this is the reason we have seen it only about 4 to 5 patients, but they're very difficult to treat, become intractable uveitic patients. And this patient has uncontrolled diabetes always, so this could also be another reason for inflammation. Corneal decomposition is a serious issue. Tube exposure, as we mentioned, it can happen very late also, and beware of ongoing strabismus, exotropia, esotropia. So if you have a exotropic eye and you put the tube intranasally, very high chance of nasal exposure, because the tube, the tension track, the tension caused on the conjunctiva is huge by the lid margins and other things. So you have exposure. If you have a esotropia and you put the tube in supratemporally, you have a very high chance of exposure. So be careful with strabismus, pre-existing strabismus. So this patient did not have a patch graft, but you can see that it's exposed because of constant rubbing of the eyelid, and then we redirected the tube into a different space, and then she's doing well now. Endophthalmitis, late tube issues can cause endophthalmitis. So this patient, if you see a pus, this patient had a peritubular pus collection. Okay, it can be seen very clearly here. You compress the conjunctiva, the pus will ooze transconjunctivally. You could culture it. And then you put the gonioscope, you see a cuff of pus all around the tube. So this has to be explanted. So this was published in Ophthalmology Glaucoma as a picture and perspective. So endophthalmitis, you have a very high chance in pediatric age group. ABC study mentioned 2%, TVT 1%, and our own series had 1% incidence. So tube blockage, it can be blocked by vitreous, iris, tube movement can also block the tube tip, and you have a loose sommering ring that can also block the tube. So I'll stop here. In summary, GDs are a big boon for glaucoma surgeons. Principles of surgery have to be adhered to very strictly, and you have a significant learning curve, but it's not insurmountable. Thank you very much.
Thank you so much, Ganesh. That was, whirlwind, but it did cover everything. And, one has to be aware of complications that can happen with tubes, to be prepared. I re-invite Dr. Amit Pandey. He's going to summarize some of the, major evidence that we have with regards to tubes. Amit.
Thank you again, ma'am. So I'll be talking about these 4 landmark studies: the tube versus trab, the primary tube versus trab, Ahmed versus Balwilt, and Ahmed-Balwilt comparison. These studies have shaped our understanding and management of glaucoma surgery, and I'll be reviewing their aims, methods, results, conclusions, and limitations. Also, we'll have a discussion on the clinical implications in our practice. This is stopped. Okay. So the first one is the tube versus trab. The aim was to see the safety and efficacy of tubes versus trabeculectomy with mitomycin in patients who had previous ocular surgery. Previous ocular surgery being either cataract surgery or a filtration surgery, but patients who had extensive scarring of the conjunctiva were excluded. All these studies are multicentric randomized control trials. They had 212 patients randomized into either Balwilt, which 350 mm square, or a trab 0.4 mg per ml for 2 minutes, and they saw the IOP and safety. At 5 years, trab had better IOP control, but not clinically significant. What do you call it? It was statistically not significant. Yeah. And failure rates was also a little higher with trab group. The change of visual field damage progressing was slower with trab group, but again not statistically significant. They identified diabetes, high IOP, and more severe visual field loss at baseline were the risk factors for progression. Complication rates were also mentioned to be higher with the TRAB group. So the key findings was that I'm not going to go too much into statistics and numbers, just going to highlight the key findings. Success rates, they told that the tube had higher cumulative success rates at 3 years and 5 years, and IOP reduction was also similar in both the groups. In the early postoperative phase, the TRAB, that is the first year, TRAB group had better IOP control than the tube group. Complications were more with TRABs, but late and serious complications were similar in both the groups. Wound leaks were more frequent with TRABs, and diplopia and of course motility disturbances would be higher with the tube group. Vision loss, no significant difference at 3 years and 5 years, and medication use, TRAB had lesser medication use in the first year, but again with time it became similar to the tube group. They concluded that tubes may be a little more effective in maintaining IOP control with fewer complications, and but they did not conclude that one procedure would be universally superior. Instead, it provided a comparative insight for us surgeons to make individualized decisions. The limitations of the study were that one thing is that this was partially standardized surgical techniques. Some major part of the surgeries were not standardized across all the centers. Coming on to the second one is the primary tube versus TRAB. Like I told, the first study had a previous surgery. This was without any previous surgeries. They randomized into Barwelt versus TRAB, and had similar IOP at 3 years. Failure rates was also comparable. More complications with TRAB. So they concluded that the primary tube surgery may be a viable alternative to TRAB because of lesser complications. But again, limitation was that this was only Barwelt, so it might not apply to the other implants. This was one more publication out of this study about reoperation. This was interesting. Reoperations of glaucoma in these two groups. Tube had much higher reoperation rate than TRABs at 3 years, and those patients who underwent a reoperation, in them IOP control was at the end of the study was similar, but the number of medications in the TRAB group was lesser, again not statistically significant, and the probability of failure was also significantly lesser in the TRAB group, but they could not reach significance statistically. Coming on to the third one, it's the Ahmed versus Barwelt. They compared the Ahmed with the Barwelt in refractory glaucomas. 238 patients randomized to either Ahmed FP7 or Barwelt 350. At 5 years, Ahmed had lesser, the Barwelt had the lesser mean IOP. Failure rates were higher with Ahmed, and complications, hypotony related complications were more with Barwelt. Barwelt provided a better long-term IOP control but higher initial risk of hypotony, and Ahmed had fewer complications early on but was less effective in the long term. A similar study, the Ahmed-Barwelt comparison, also compared these two devices and had similar results, with Barwelt getting better IOP control, lesser medication burden, and Ahmed getting higher failure rates. Okay, so what do we imply from, what implications do we derive from these studies, especially for our practice in India, is that we get a lot of late presentations. So these surgeries are very significant for us, and TRAB, I would say that TRAB still remains the first line surgical option in these late presenters or advanced cases because of the cost effectiveness also. Tube implants should be considered for higher risk cases, including failed TRABs and secondary glaucomas. Affordability and accessibility is something that we need to understand. So the conclusion is that the value of these landmark studies does not come from showing superiority of one operation over the other, but rather in providing comparative data on the outcomes of both surgical procedures, that help the surgeons in selecting the most appropriate glaucoma operation for their individual patients. Thank you so much.
Thank you so much. And this last presentation really is about bringing out points for discussion based on everything that you've heard today. It's not moving. No. Yeah, now. Yeah. So you've heard about all the landmark studies, and we've had some studies in India also, may not be RCTs and may not be multicentric, but basically, not moving. Not moving. Yeah. So both are effective in reducing IOP and AGM. Please remember that. Non-valved ones are able to achieve lower IOP with fewer medications, but they have slightly increased incidence of hypotony, and this is something you need to be aware of. Overall failure rate is also lower with non-valved. So the key points really are, which tube is better? Again, you know, is there any one superior over the other? You have to choose based on the knowledge you have with regard to all these tubes. Even though non-valved have complete success rates better across all studies. Which tube is cheaper is a consideration we have to keep here in India. And of course, the Orolab aqueous drainage implant, or the ADI, is very cost effective for us. It's indigenously developed and it has been designed on the bar weld. Bar weld is not available in India. And which tube reduces IOP more with lesser number? You know it's the non-valved. ACP, the Ahmed Clearpath, is the newer non-valve which only recently got introduced in India. We don't have so much data coming out of India, but from what I picked up, they are comparable to the bar weld. The advantage, there's a very significant advantage, that you need to only open up a small part of the conjunctiva. The plate size is smaller, so you can place it between muscles. These tend to have massive advantages where the conjunctiva is extremely sick. And of course, I showed you this photograph. You tend to get very diffuse blebs when you compare it to valve tubes. So which one to choose? Basically, if you want an immediate reduction in IOP, it's a no-brainer. You need the valved one. And you need to look at safety aspects in advanced glaucomas, one-eyed patients, and at the end of the day, it depends on patient and surgeon's comfort level of which tube you're going to choose in which patient. So we're coming back to the same thought process, that you customize your treatment based on the patient who is in front of you. Thank you very much. So I'd like just to kick off the discussion, unless there are some questions from the audience, what is your practice in silicon oil? What do you do, inferior tubes?
No, I still do a superior tube. I'll put a superior tube.
Okay.
With the oil removed, of course.
Yeah, but then you still have the emulsion hanging on in the eye,
okay,
and
yeah.
it then tends to block the tube.
Yeah, we don't put a inferior.
Superior tube. I don't do it inferior, at least for the first choice, first time. And we do find the emulsified oil, as the patient is on the table lying flat, like the one video I showed initially, that was actually AGV SOR removed silicon oil, emulsified. You go in and wash. Of course, you keep washing, it's going to keep coming again and again and again. But again, wash as much as possible.
Exactly,
and
exactly.
Superior.
Same with you guys?
Yeah, silicone oil, if it is there, a recent silicone oil, not an emulsified one, I would ask the VR surgeon to first remove the silicone oil. Yeah. And at a second stage, do a tube implantation if the IOP is still not under control. In emulsified oil, I think if it is very significant, again, not removed, then complete removal of the silicone oil. If only a bit of it is there, I think, with the wash.
You know what, Amit? If glaucoma has occurred and it's not within 1 month, it's 3 months later.
Yeah.
is the oil.
Yeah, I know, and I explained the
So,
patient
removal
beforehand.
of the oil actually doesn't make
Yeah,
any difference.
but I explained to
found
the
that.
patient that you will require a glaucoma surgery, but we'll do it in a staged manner because I had a choroidal hemorrhage in a SOR with tube implantation done together.
Okay.
Not to do the same
Anything
time.
else, Jayant, you want to add? Or?
Had very little experience with silicone oil tube, but tubes do work. And but I find the oil keeps coming back, the globules, small ones, coming even after all the removal. So I just go in the anterior chamber and keep removing SOS. Not always too frequently because endothelium can go. But just remove them because they tend to.
So
and I
wash
also
out
do.
SOS.
SOS wash out, and it's not that difficult to wash them
Someone
out.
else? Yes, please.
I'm not a glaucoma specialist, I'm a retinal surgeon. Just wanted to ask you, what would you do if the oil cannot be removed? There are eyes where you cannot remove the oil because we know recurrence can occur, but this glaucoma has to be still managed. What would you do?
No, I do tend to do quite a few tubes with the oil in situ. My take on silicone oil is I do go superior, I don't go inferior. Inferior, I've burnt my fingers. I find that oil tracks subconjunctivally and then you get subconjunctival silicone oil particles. So what I do and what has worked now is I make intraocular fenestrations. So the particles go and stick to the fenestrations and the tip of the tube is still free. Yes, it doesn't get blocked. So this has worked quite well. Even when silicone oil, recurrent RDs and silicone oil has been placed again and again, it works. It has worked.
I have an alternative suggestion. I'm wondering instead of. Can you hear me? Sorry, I have an alternative suggestion. I think this is obviously, thankfully, not that common a problem, but when it happens, it's quite irritating. And when you end up doing very invasive procedures, it could lead to problems, as we are seeing. Sometimes using a micropulse diode or even a diode laser, a limited diode.
We do that too, sir.
Has worked beautifully in these cases.
We do a limited diode.
A limited
for those
diode.
patients.
I think that solves the problem for many of my patients. Not that many.
The one suggestion I have is that if a VR surgery also has to be done at the same time, you can ask your VR surgeon to do a endo CPC rather than doing a transcleral, which makes it much more easier.
Absolutely.
Okay, and if it's a pseudophakic eye, then of course you can do your routine tube implant. But I don't see any objection to putting a tube inferionasally if there is a aphakic eye where you're always concerned about the oil trying to migrate through the tube. Is there quite an objection to putting the tube inferionasally?
What happens is that the oil tracks down the tube and then presents itself subconjunctivally. That has happened pretty often.
Slight
where,
increasing chance of endophthalmitis also with inferior tubes.
Yes and no.
And where ECP is concerned, probably I'm the only one doing, as a glaucoma specialist, doing ECP in the country. And I have looked at my figures. Actually, silicone oil glaucoma is the worst prognosis where ECP is concerned. So, I'm trying to move away. I do offer it because it's a MIGS at the end of the day. It is very small incision, very quick surgery. So I do offer it as the first stage, but I find quite a few of them actually end up either getting a tube or I'm doing a transcleral diode for these patients also.
To answer Prof. Gopal, anecdotally, I've done inferior tubes for some silicone oil patients, and they have worked well because some other surgeon. So I've seen a flip side, so I can see both ways. I see your point. I totally get it as well. But where they did a superior and got blocked, so I did inferior nasal and it worked well. But it's N of 2, N of 3. My numbers
I think
are very
by
low for
choice,
this.
we probably would not. None of us would probably do by choice the first tube as inferior.
Fair
Maybe
enough.
second tube would probably consider inferior, inferior-nasal.
Or a second procedure. In fact, if you do a diode and then it doesn't work, then you do inferior nasal tube.
Is there any other point? Yes, please. Please use the mic. As you would manage any decompensation, if the tube is in correct position, it's not anterior, it's not touching the endothelium. If that is the case, then you have to reposition. There is no doubt about this. But if the tube is in good position, then you start by giving some, topical
Hypersolid.
steroids. You may even give oral steroids. You can give hypertonic saline. You can take these measures first.
Also,
Before.
sometimes it's the disease, like in eye syndrome, it's the disease that is progressing because it's both glaucoma as well as the corneal disease. So if that is the case, again, you treat it conservatively initially. If not, then yeah, you need to do something about it either.
Yeah, I think
Actually, this patient is around 45 years old, keratoconus bilateral PKP, and she developed cataract in one eye. I did phaco and AGV, 1.0 CDR. So both eyes, 1.0 advanced glaucoma.
Is the tube long?
No, this first
Adequate.
one was okay. There is no problem. The second one, it was already pseudophakic and had a graft. So she is maximum medical therapy. She doesn't want to use drops. So she requested me to put an AGV in the other eye. So I put a AGV in this eye. Tube is in very good position, not touching.
So it's
the eye,
probably
is
the
not
rejection that is happening. So you need to
See-
treat it accordingly, like a rejection only.
touching. Yeah, and it
But if
started
you had to,
developing-
I think if you need to do a second PKP later on, then you might trim the tube or put it in the sulcus.
But I would like to make
the
another
anyway
point
to
here. If a
prevent
patient,
getting
patient
further
does
damage.
not want medication after surgery, AGV is not a good choice.
That's true.
Yeah. You have to, if you're giving 4 or 5 medications after AGV, you find you're still doing 2 or 3.
Yeah.
So it's not a good choice.
And
If you
can-
really want to get rid of medication, you have to start thinking in terms of non-valve surgery.
The tube, the localized decomposition should start near the tube entry.
Correct. If tube is
That's
the
where it starts. If it is
reason.
any other area, then it could be related to
Actually,
the general
it's the
condition.
graft which is getting decompensated.
Yeah.
Uh,
it's
then
not
it's
because of the
problem,
tube,
Yeah,
yeah.
tube. Yeah. But if you're going to do a regraft or if you're going to do some procedure, redirect the tube into the sulcus.
Exactly.
That will solve
You
your
have
problem
to,
the next
yeah,
time.
You have to.
Because the next graft survival is going to be 60%, 65% of the first one. You're not going to get as good a survival rate as the first
we
one.
do that quite often actually. Most of the time these kind of decompensated corneas due to corneal problem primarily. So what we do is we do a desec or now we do the SPEDEC procedures in which I redirect the tube into the under the iris.
Yes.
And so there is
At
and
the
then
same
do
time,
this-
at the same
Sulcus.
time.
Yeah.
Do both
So
at the same time.
actually, it's a good idea to put it in the sulcus in the first
first
place. If the
place, true.
patient is pseudophakic
Yeah.
or aphakic, there is no reason. Sometimes it's difficult. I've had problems with the pseudophakia being done elsewhere, and you don't know, whether there were complications during surgery. And when I am doing the surgery, I'm seeing zonular dehiscence and vitreous coming. That's a different matter. But generally speaking, I would say put it in the sulcus.
So is that the message that if you have space and it's pseudophakic, would you put it in the sulcus
Yes.
generally
Always.
also?
Yes.
Yeah.
Yes.
So I think that
Yes.
message is, if you can
Yeah.
just
Yes.
clear
So
once.
putting it into the sulcus, is it easy, madam?
It is
No.
not difficult. You have to bump up the sulcus, and you have to go 3 millimeters behind the limbus to enter.
3 millimeters.
Yes.
Thank you. so
Okay,
much.
I think we've taken up enough time. I do thank all my co-instructors. It started off as an empty hall, but we are glad we had some audience and some questions. Thank you very much.